Hi everyone, we're going to talk about the second part of eyes. I anticipate there's probably going to be a third. So this first thing that we're going to talk about is retinopathy of prematurity. And it's a multifactorial retinal vascular disease caused by early gestational age and low birth weight. It involves abnormal growth of the retinal vessels in incompletely vascularized redness of the areas of the premature infant. The condition is classified according to the distance of vascularization has progressed away from the optic nerve, the severity of inflammatory changes, the extent of the disease, the presence of other diseases, scarring patterns, and the presence of rush disease. The condition is diagnosed by a pediatric ophthalmologist where the infant is usually seen in the 32 to 44 week range post-conception. So premature infants that post-conception at 32 to 44 weeks. At discharge, you may see some of the following for these little guys: leukorrhea, pupillary rigidity, vitreous haziness, hemorrhage, cataracts, detached retinas. The management is by an ophthalmologist, and so it's important to work in conjunction with them. The role with the PCP is in managing retinopathy of prematurity is to ensure that all infants that fit the criteria, even those that have had the condition resolve, receive the follow-up ophthalmological exams that they need by the specialist. All right. Some complications include retinal detachment, strabismus, amblyopia, myopia, and astigmatism, and anosopria. You can have cataracts, uveitis, macular burns. You can have occlusions to the retinal artery, glaucoma. The prevention is most important in decreasing premature deaths, and it's important that with premature babies that to have monitoring of their oxygen to keep their SATs between 90 and 95%. Another condition that we're going to talk about is retinoblastoma, and it's an intraocular tumor that develops in the retina. And although it's a rare tumor, it is the most common tumor in children, making up 3 to 4% of cancers in children younger than 15. When assessing for retinoblastoma, a good history is needed, including any family history, any history of strabismus, unilateral or bilateral leukorrhea, any decreased visual acuities, any abnormal red reflex. Management includes a referral to an ophthalmologist, and enucleation, which is removal of the eye, may be undergone for advanced tumors. So some complications and prognosis. For a unilateral retinoblastoma, there is a very high cure rate of 95%. Next, let's talk about some infections of the eye. They're the most frequent ocular disorders in pediatrics. They can be bacterial, they can be viral, or they can be fungal. Here's a few pictures. You can see the swelling and the drainage coming from the eye, the exudate around the lashes. And in this picture, there's just more redness to the lower lid. So let's talk about some conjunctivitis in the newborn. At that particular time, it's called ophthalmia neonatorium, and this typically occurs in the first few months. Chlamydia is the most common cause. It's seen primarily in the first 5 to 14 days. Some organisms that might be seen could be C. trichomonas, seen in 5 to 14 days. You may see moderate eye swelling and purulent discharge. With gonorrhea, it's usually seen in 3 to 5 days, and you might see acute conjunctival inflammation and excessive purulent discharge. And for herpes simplex, it's seen at birth with mild conjunctivitis, redness, and a serosanguinous discharge. Some diagnostic studies that are done in newborns to determine what the organism is include swabs and scrapings. Management includes irrigating with sterile saline. If the bacterium is known to be gonococcal, then treat with an IM ceftriaxone. If it's not non-gonococcal, then treat with topical antibiotics. Herpes simplex requires immediate hospitalization and treated with both topical and systemic antivirals. Chlamydia, you need to assess for any systemic infections and treat with systemic erythromycin for approximately 14 days. Bactrim can be a good alternative in this neonatal period, and although azithromycin and clarithromycin have been used, they are not FDA approved for this age group. So some further management, if mom or partners if baby is infected, then mom or others that are associated with baby should be treated, and prophylactic antibiotic eye drops, ointments are given within the first hour of birth to help prevent any issues with conjunctivitis in newborns. Inclusion conjunctivitis caused by chlamydia. There are apparently one of 8 strains of chlamydia that can do this. You may see this in moms that have had a maternal history of an STI. You will see conjunctival redness, which could be mild to severe and have a mucopurulent discharge. You may see some reaction to the eyelashes. The diagnostic studies that would be associated with this would be isolating the organism so you can narrow down treatment. Management includes systemic therapy with an erythromycin or other macrolides, and some complications that can happen include chlamydial pneumonia and nasopharyngeal colonization of the organism. So bacterial conjunctivitis, also known as pink eye, is very common in little ones, but it is contagious and easily spread. H. flu is the most common organism that it is seen with, and kids who are younger than 7, it is seen in, and is most commonly noted in the winter and seen in toddlers and preschools. Clinical findings may include redness, yellow-green purulent discharge, crusty eyelids when wakening, burning, stinging, or itchy, sensitivity to light. You may have some petechiae in the conjunctiva. You may also see symptoms of an upper respiratory infection, and there should be a normal vision screen. Usually diagnostic testing is not necessary, but it may be considered if there is a lacrimal duct obstruction in kids, in infants, if you're seeing some, let me back up here. Diagnostic studies are not usually needed. Some differential diagnoses for bacterial conjunctivitis could include a lacrimal duct obstruction in infants, ear infections, Kawasaki's, a foreign body, or a corneal abrasion. Management, this is a self-limiting condition and may resolve on its own. However, children who receive topical antibiotics seem to have a faster clinical improvement and can go back to work, school sooner and cause less parental work loss. Something to note, though, is if prescribing antibiotics for conjunctivitis has led to an increasing rate of drug resistance. So use caution with prescribing. Make sure it's bacterial and not necessarily a viral or allergic. Make sure that you're using a broad spectrum antibiotic that has the lowest resistance rate, has good compliance, and good penetration of the tissue. You also need to take into account the cost of antibiotics because they can vary significantly. Cost should be favored in when prescribing. If you look on page 723 in the new book, there is a section there, and I'm sure it's in the old book as well, on different treatment options. It's important to not use aminoglycosides as they can cause hypersensitivity, some severe allergic reactions, and maybe increased drug resistance. So another condition called conjunctivitis otitis syndrome is the H. flu has caused both an eye issue and an ear issue. And so it's important to treat for otitis media, which is usually H. flu, and they don't need duplicate antibiotics. Patient education is important to clean the eyelashes several times a day with warm water or something like Johnson's baby shampoo. Applying warm soaks to the eye 3 or 4 times a day makes it feel better. Washing hands frequently to help prevent spread, encouraging little ones not to touch their eyes. Complications are if the symptoms are severe or do not respond to antibiotic treatment. So viral conjunctivitis is usually caused by the adenovirus, which is the cold, but it can also be caused by herpes simplex, herpes zoster, or an enterovirus, a molluscum, or a varicella virus. It's most common in children greater than 6. Some clinical findings include tearing, clear watery discharge, fever, headaches, lack of appetite, upper respiratory infection, sore throat, itchy, red, swollen conjunctivitis. You can have swollen eyelids. You can have sensitivity to light, and you can have some herpetic vesicles that might pop up on the eyelids. For management of this, the most important thing is good hygiene. Apply warm or cold compresses, whichever feels better. Artificial tears to help with the dryness. Antibiotics are not recommended. Antihistamines or vasoconstrictive solutions may help with the allergic symptoms. If there's concern that is herpes simplex, then it needs to be referred immediately. And if there's concern that there's molluscum involvement, then it needs to be referred for excision. So there's also another multi-condition called conjunctivitis pharyngitis syndrome, and it is mostly suspected to be caused by the cold and not bacteria. One of the concerns that you can have is that there can be involvement of the deep layers of the cornea, and those can become inflamed, and there can be scarring, which can lead to blindness. So if you're having some concerns about the eye and associated with throat issues, it's better to refer. Allergic conjunctivitis, and it's associated with mild swelling to the eye. It can be seen in kids and even can occur after adolescence. There are a couple of different types. We have the hay fever associated, which is mild itching and swelling. The vernal, which is more severe. We have an atopic keratoconjunctivitis, which is an atopic dermatitis associated with that, and asthma. There is one that's called giant papillary that's associated with contact lens wearers. Some clinical findings include severe itching and tearing, family history. You may see rhinitis, eczema, or asthma. It's precipitated by allergies, and there'll be redness and swelling of the conjunctiva and the eyelids. Other clinical findings may be reaction to the follicles, stringy mucoid discharge seen in both eyes. You can have cobblestoning of the papillary areas. You will have a normal vision screen. Only diagnostic studies that would be looking for eosinophils, which are always noted in allergic type reactions. Management includes prevention, avoiding the allergens, washing hands and face. For kids that are outside playing a lot, coming in, taking off the clothes they are wearing while they're outside, and if it's not time for a bath, putting on a fresh set of clothes, especially a shirt. These kids need to take showers before they go to bed to wash away all of the allergens. If not, they're just putting the allergens right against their face on the pillow. Often saline solutions help wash out some of the allergens, and some topical decongestants and antihistamines are beneficial. Blepharitis is an acute or chronic inflammation of the eyelash follicles. Some differential, you can the clinical findings, the swelling, the redness. You may have some flaky, scaly debris on the eyelid margins. You have to rule out that it is not lice. You may feel a gritty, burning feeling. As we said, one of the differential diagnosis could be lice of the eyelashes, so pediculosis of the eyelashes. Here are some pictures, and you can see where some of these little marks here could be indication of concerns that you had some lice on the eyelids forming. All right. Also, for the management of this, the eyelashes need to be cleaned with with Q-tip and a weak solution of a no-tear shampoo to get that exudate off. Applying warm compresses often makes them feel better. You may need to use like a topical anti-staphylococcal antibiotic. You can also see associated with this some seborrhea, psoriasis, eczema, allergies, things along those lines. Patients that wear contacts should not wear those at these times. They should wear their glasses instead, and artificial tears can help them to not feel quite as dry and gritty. Okay, a horgillum, which is also known as a stye, is an infection of the sebaceous gland. You can see it on the eyelids. It can be a tender, swollen furnicle. Differential diagnoses that you have to rule out is cellulitis, depending on the involvement of it. Management, likely this patient will have a spontaneous rupture of the area. Applying warm, moist compresses makes it to feel better. You could use an anti-staphylococcal ointment. Steroids are not indicated, and if the area does not open on its own, you could refer it to have an IND. So here's a picture of it, and you can see how it's pretty large, and it's drooping down into the eye, and how that would get into your visual field and be bothersome to you. Okay, next on our list we have chalozion, which is a chronic sterile inflammation of the eye, which is from a lipogranuloma. You can have mild redness, slight swelling. You may have a slow-growing, round, non-pigmented, painless mass. Hot compresses are helpful for acute lesions. Refer for surgical incision if unresolved or for cosmetic purposes. One of the only complications of this is it does reoccur commonly. Here's a picture of it. And so some nasolacrimal duct conditions. Dacrostenosis is an abnormal obstruction of the tear duct. Dacrocystitis is inflammation of the tear duct. And so we often see these in infants or little ones. You can have continuous intermittent tearing and a mucus discharge. You can have that redness of the lids and the lashes, nasal obstruction and drainage. You can have redness of the tear sac, and infection may occur. If there's an obstruction and you're worried that that duct is not going to drain, there's always the concern that you could have an infection with that fluid that continues to accumulate there. So it's important to identify that. Some diagnostic studies that may be done: CBC, a culture of severe differential diagnoses include conjunctivitis, a foreign body, corneal abrasion, or an intraocular inflammation. Management, as we just talked about, you want to minimize the fluid just stagnizing there, prevent infection, daily massage of the lacrimal duct, antibiotic ointment or drops if needed, saline drops to the nose to help keep things flowing, and refer to an ophthalmologist if persistent or severe. And you want to make sure that there are not any issues with periorbital or orbital cellulitis. And so this is a picture of a little one who has had this issue. So for periorbital cellulitis, you can have a trauma or focal infection near the eye or the sinuses. It is usually secondary to other infections. You may see an acute febrile illness. You may have swelling, a redness to the tissues around the eye. The eyelid may have a deep red. You may see the patient having some symptoms of infection like a sinusitis, pressure in the head, fever, things like that. You may notice orbital discomfort, propoptosis, and you may even see some paralysis of the extraocular muscles depending on the amount of involvement. So here is a example of a child with periorbital cellulitis. Um, some diagnostic studies may include CBC blood cultures or cultures of exudate if noted. If this is on a little one less than a year old, that you may see a lumbar puncture performed. CT to rule out sinusitis, orbital cellulitis, or any form of an abscess. You want to check visual acuity so you can assess extraocular movements and pupillary reaction testing. Some other differential diagnoses that you might want to consider are conjunctivitis, a sinus clot, or orbital cellulitis. Management in the outpatient setting can be done if it's mild, if the orbit is not involved and there's no systemic symptoms and the patient is older than a year old. You would use oral antibiotics and warm soaks. But if it's more considered moderate to severe, you would require hospitalization and IV antibiotics. Some complications may be more of an orbital cellulitis versus a periorbital. There may be abscesses, meningitis. There is a condition called panophthalmitis, which is inflammation of the layers of the eye. And so those are important things to keep in mind. Further talking about the eye, some keratitis or corneal ulcers. It's an inflammation of the cornea. You see a dramatic alteration in the visual acuity. If one of these occurs, blindness can result. Trauma is the most common risk factors. Some things that you have to be aware of. Some clinical findings is exposure to infection. Illness, trauma, extended contact lens wear, foreign bodies, or an unresponsive conjunctivitis may be seen. You may see white lesions on the cornea. You may see vesicles on the eyelids. There could be pain, sensitivity to the light, tearing, and redness, and you can have blurred vision. The concern is, as we mentioned with the corneal ulceration, that blindness may occur. Trauma is the most common risk, and using a fluorescein dye will show you whether you have one there, and I believe we have some slides that will talk about that. Management, if you have keratitis or corneal ulcer, require immediate referral to an ophthalmologist. Do not try to treat. Steroids should never be used. Complications can include opacification, scarring, or loss of vision. So, we're talking here about inflammation of the uveal tract, and that includes your iris, your ciliary body, and your chorioids, and any adjacent ocular structures. This inflammation can be acute or chronic. It can be infectious or non-infectious. Etiologies may include viral versus bacterial, trauma, allergy, malignancy, Kawasaki's, herpes, TB, Lyme, CMV, infection, Stevens-Johnson syndrome. You see that there's an acute onset of pain. You have a red eye, sensitivity to light, blurred or decreased vision. You can have excessive tearing and redness, and then the hypopyon is a cloudy appearance with bulging iris, and those are the inflammatory cells that are in the anterior chamber of the eye. And so with this, you also have to rule out, is there any conjunctivitis? Management is treating the underlying systemic disease. So this requires referring to an ophthalmologist for treatments. Complications could include changes in intraocular pressure, corneal edema, changes in your vision, scarring of the eye, retinal detachment, glaucoma, cataracts. Trachoma is a chronic infectious disease of the eye. You see Neovascularization of the cornea. It is contagious. It is not seen in the U.S., or it's very rare in the U.S. It is spread from eye to eye by flies. It's the second leading cause of blindness in the world, though, and as I said, rare in the U.S. Clinical findings may be showing inflammation, pain, photophobia, excessive tearing, granulation on the follicles, and entropion. Okay, we're going to end here and then we'll finish up with the injured eye.